Good evening and welcome to our webinar series on emerging dental techniques. My name is Matthew Garrett and I'm the Dean of the Faculty of Dental Surgery. It gives me great pleasure to introduce Professor Chris Deary, who is our speaker this evening. Chris is the Dean of the School of Clinical Dentistry at the University of Sheffield, where he holds the position of Professor and Honorary Consultant in Paediatric Dentistry. As a way of background and introduction, Chris graduated from Edinburgh in 1984, and following periods in general dental practice and the community dental service, he completed a master's in child dental health at Bristol University. Following this, he moved north of the border to Dundee, where he worked at the Scottish Executives DHSRU and the Children's Dentistry Department. He was appointed as a consultant in paediatric dentistry at Edinburgh Dental Institute in 2001 and took up chair as in paediatric dentistry at the University of Sheffield in 2006, where he is now the Dean of the School of Clinical Dentistry. He's been chair of the Dental Schools Council and also the Consultants in Paediatric Dentistry Group. In all of these roles, he's been very committed to improving dental education and dental care in the United Kingdom. His research interests include research with primary care, cariology, and evidence-based dentistry and research involving children. He's been involved in trials totaling 10.5 million, including currently being chief investigator on the NIHR funded MAGIC trial. As I say, it's a great pleasure that I can introduce Professor Chris Deary, who actually taught me paediatric dentistry for a time in Edinburgh in 2001. He may not remember because he probably had so many trainees, but he was a fantastic teacher and an inspiration to many dental trainees. So we're absolutely delighted to have Chris here this evening, who is going to talk about
So Matthew's internet has been freezing all afternoon, so he said to jump in, so I will jump in and say thank you very much for that kind introduction. And of course I remember you, Matthew, and I also remember what an excellent junior member of staff you were in this mutual admiration society we're running, but that is the honest truth. So I'd like to thank the faculty in the college for inviting me to speak this evening, and particularly I'd like to invite all of you who've joined us and joined me on your Tuesday night. So with no further ado, I will commence the chat. So for some reason, there we go, I can see my slides now. Current concepts in cariology, and I've tried to make it relevant to general practice and not so much just in specialist practice. So quite a long list of aims and objectives, but and some of them I'm just going to touch on the concepts and where things are actually changing and getting quite exciting, but maybe the evidence is following. So going to first of all make the case for why caries matters. I've spent my life pretty much doing research into caries and caries diagnosis in particular, so I can both have written on it and think it's really important. So I'm going to try to make that case to you, although if you joined this evening you probably believe that already. Discuss where we are on the evidence base for biological and a minimally interventive approach to care. I'm going to talk about the ICDAS International Caries Detection and Assessment System and hopefully persuade you that it has some advantages and is not actually a challenge to bring into practice. I'm also going to talk about risk assessment and how you bring together the knowledge you gain from ICDAS with your risk assessment to plan your care for the patient and also to plan your care for the tooth. Then I'm going to speak at sort of the two ends of the caries process, managing caries before cavitation and then managing caries when it's deeper. I have a particular interest in preventing caries in erupting teeth, because those are the teeth, certainly in the child and adolescent group, obviously because that's when teeth are erupting, but that's when most teeth become carious, until perhaps the other end of life, which I know less about. And I'm going to finish really talking about silver-diamine fluoride SDF and the potential I see in that for the future. So if you look at the Child Dental Health Survey from 2013, which is the last time this study was done, 14% of 5-year-olds and 20% of 12-year-olds in England said they'd had toothache in the last 12 months. This presented itself as difficulty eating, loss of sleep, with associated tiredness at school, time off school either because of the dental pain or because of having to get dental treatment. Ironically, problems with toothbrushing, because if your teeth hurt, when you brush your teeth, you don't brush your teeth and you get that vicious cycle. And interference with social activities, again because of pain or because of having to visit for dental treatment. Further impacts, if 5% of 5-year-olds are walking about with frank dental sepsis, so that's not something that I would find or you would find by looking at an x-ray. It's they've got a sinus, they've got a fistula, they've got a swelling. We know, and there's quite good evidence, and if you want to read a really excellent, very short paper on it, it's by the late Professor Aubrey Shyam in the BDJ in 2007, where he very eloquently put together the arguments for the effect caries has on the systemic health of children and their quality of life. So children who have severe early childhood caries fail to thrive, so they're lighter and smaller than their peers. And also because of the inflammatory mediators going about, they actually are 6 times more likely to have iron deficiency anemia than their peers. So it's not just because they've got caries because they've got a poor diet and therefore they have anemia. It's actually more complicated than that. Another way of looking at this impact is the number of GAs, and again we'd like to thank the faculty and college for all the support they've given paediatric dentistry in making the case that this is just appalling and unacceptable. I've used slightly old data because last year's data is pretty meaningless with COVID. So we have almost 50,000 children admitted to hospital for treatment of dental caries. So that means a GA. And for a child between the age of 5 and 9, it's the most common reason a child is admitted to hospital for an operation in any part of the UK. That's 30% of all general anaesthetics, £30 million of English NHS money spent, and the number is increasing despite declining caries rates. So, caries. So caries has a big impact. There are a couple of thoughts, if you remember nothing else from what I say this evening. One of them is this, that caries is driven by the biofilm on the surface, or the plaque on the surface. If you have no biofilm, you have no caries, and it does not matter how advanced that lesion is. That's why I've got that E in the upper right-hand corner as we look at the slide. It's broken down so much, it's been self-cleansing. I admit the patient has discovered they have a toothbrush, they've started to use a fluoride toothpaste, they've maybe altered the diet, but why that dentinal caries, which is almost in the pulp, has stopped is because there's no biofilm on the surface of that caries. So if we can eradicate the biofilm, we can stop caries. So you isolate the caries from the biofilm on the surface by covering it, or you brush it away. I'm not saying fluoride doesn't matter, it matters, but in the very concept of caries, this is what matters. So a little bit of history. Enamel caries, all of you will remember your oral pathology textbooks and the 4 layers of the enamel caries lesion, and in the early 70s, we realised that this was not purely a progressive disease, that it sits in equilibrium, going from times of remin and demin. And we're dependent on that for the action of fluoride and some of the other agents we use. Around the same time as this work was being discovered, some workers in Japan, Fujiyama and Terashima, described dentin caries differently to our standard 4 layers of layer of demineralization, layer of bacterial invasion, layer of destruction, layer of sclerosis. Now, those are all there. I'm not saying they're not there, but they described it in what is actually a much more clinically meaningful layer of an infected layer and an affected layer. So the affected layer is nearer the pulp. Yes, there is damage to the dentin structure and demineralization, and there are bacteria present, but there are far less bacteria present than in the infected layer, which is nearer the surface. And what's particularly important about that infective layer is what's happened to the collagen. The collagen has been denatured, the scaffold that the dentin has been built on, to such an extent that remineralization is not possible. And as I said, the information we have about enamel caries and this work from Japan all arrive about the same time. We pay attention to a much larger degree to what we're being told about enamel caries, and really this work from Japan is pretty much ignored until well into the 1990s, when we start to think, actually, maybe we don't need to remove as much dentin as we were taught. Other things to consider related to that are the levels of infection, and looking at a dentin caries lesion, if the lesion's uncavitated, until the lesion extends 1/3 of the way into the dentin, the lesion is not significantly infected. So it's only when you're deeper than that in the inner 2/3 that you've high levels of infection in the dentin. And stating the obvious, but you still have to state the obvious because it's not always true. If a lesion is cavitated, it's more infected. And similarly, if a lesion involves more than one surface, it's more infected. Dentin and the pulp are one complex. And for a long time, we've considered the pulp in particular to be quite helpless and unable to defend itself from caries. And I've often used the analogy to an old-fashioned Disney princess who is not capable of doing anything until Prince Charming comes riding along on his stallion to save it. In fact, the pulp is like a modern Disney princess and is well capable of looking after itself, and actually could help Prince Charming out if he needed it. One image here is of a healthy pulp. The other image is of a micro CT image from my paediatric dentistry colleague, Professor Franti Wong at Barts. He took this image to show the shape of the caries lesion, which is on the mesial surface. So what you're seeing here is all the hard tissue has been removed by the computer, and we can see the caries and we can see the pulp. And we can see that pulp retreating, and that's laying down secondary and tertiary dentin. And what my colleagues actually in Sheffield, Helen Rodd and Fiona Bossinade, have shown is actually that pulp is full of an immune response, neurotransmitters, and it is fighting to protect itself, and it is in no way helpless. So if you start to add the information that we've got about the structure of dentin and what's happening in the pulp with those odontoblast processes going from the pulp into the dentin, so it is one structure really, we start to be able to change our picture of how we think of the pulp, how we think of caries, and come to a much less destructive approach to the management of caries in denting. And later on in the talk, I will talk about and put a picture up of G.V. Black, and his philosophy was that denting is that dentinal caries is like gangrene. It's not like gangrene at all. And the other thing to remember is that denting is not denting, but caries is a slowly progressing disease. So you have time to watch, time to monitor, time to try prevention. So I said right at the beginning in the introduction, I have spent a lot of time thinking about caries diagnosis, and I think it is vitally important that we get our diagnostic decisions right. That seems to be stating the obvious, I know, but the correct diagnostic decision means you will make the correct restorative decision. Sadly, once you stick your burr in a tooth, no matter how good you are slowly sending that tooth towards the bin. It doesn't matter which of us say, my restorations fail, everyone's restorations fail. So you don't want to cut a tooth unnecessarily. And as I've said, you do have time to watch, you have time to prevent, you have time to see if your preventive treatment is working. That is a rather obvious statement about why we think prevention is, why diagnosis is so important. But the other reason is that it gives us, as I've said, the time to initiate the appropriate preventive regime. I'm not going to talk a lot about toothbrushing in this talk at all. In fact, I'm going to talk very little about toothbrushing other than on the erupting tooth later on. But brushing with a fluoride toothpaste is our most effective preventive agent, and I mustn't forget that or allow us to forget it. So, meticulous caries diagnosis. Down the left-hand side, we have a list of names going back to 1956 with Tommy Marthaler. That's proving nothing is new. You know, I've quoted evidence from the early 70s, now we're back in 1956, and we go on through every decade. All of these people have shown that dentists, and for that matter, dental care professionals, can diagnose caries through each of its stages, from early enamel caries, more advanced enamel caries, through the early stages of dentin caries to into the pulp, and can do that just as well when they're trained as they can diagnose just dentin caries. So it's no harder to diagnose enamel caries than it is dentin caries. You just have to have tuned your decision making in your eye into doing it. And say all these people have done it, and the last one, Jimenez et al., they've done a systematic review confirming what I've just said. On the other side, I've got 3 acronyms for meticulous caries diagnostic systems. The 2 leaders of the pack are the NIVADS and ICDAS, the International Caries Detection and Assessment System. So I'm only going to talk about them. They're very similar. The differences is that NIVADS uses a blunt probe to do a tactile assessment at an early stage. NIVAD does a caries activity score at an early stage. ICDAS does that as a second element in its process. So they're both equally good. They're very similar. I am involved in ICDAS and its development. I wasn't involved in the NIVAD system. So of course I'm biased. I prefer ICDAS. So that's my declaration. But in favour of ICDAS, there are far more studies. It's used in epidemiological studies across the world. For instance, Iceland's Public Health Survey uses ICDAS. It's the market leader with more research. I'm going to concentrate on ICDAS. But if you happen to be someone who likes NIVAD or reads up on NIVAD and prefers it, they are very similar. So son of ICDAS is Caries Care 4D. And what that does is it incorporates the diagnostic element of ICDAS, which is the detect element, with a caries risk assessment, which is part 1, a deciding what to do, a doing it, and then you go round and round because you have a recall. And that, the paper where, if you want to read more about that, is in the Martagan paper. I also reference Avi Banerjee's paper in the BDJ from October of 2020. He presents a different model. It's not Caries Care 4D, it's a minimal intervention model, but it's very similar and it's a paper worth reading. Okay, caries risk assessment, the first part of those 4Ds. Now, actually, you do caries risk assessment at 2 points. You do it when you first see the patient as part of their medical history, their social history, the other assessments you do, and then you do an assessment on the tooth when you see the individual lesion. So although 4D makes it a nice diagram, actually we all know it's slightly more nuanced than that. You all do a risk assessment every day. Whether you record it or not is perhaps different, and you should record it because there's good evidence that by recording it, you are more likely to act upon it. But sadly, the best predictor of future caries is past caries. We know children who have caries in their primary dentition are much more likely to have caries in their permanent dentition. So previous disease is a high predictor. Maybe that again is not rocket science, because telling someone who's got a disease that they're more likely to have more of the disease is really what we're saying there. Diet. We know caries is a disease that is associated with diet. It's complicated, but it is, in simple terms, high frequency of sugars. Caries, like cancer, like heart disease, is a socioeconomic disease, and those least advantaged in our society are more likely to have it for complicated reasons, but reasons we all know and understand. I've talked about toothbrushing and fluoride, and plaque levels are a very good measure of exposure to fluoride in toothpaste, but of course we have fluoride from mouthwash, etc. But use of fluoride in its total is very important to your risk assessment. Medical history. In another version of this slide, I have a girl with cerebral palsy. She's more likely to have caries because she finds brushing her teeth impossible because she doesn't have fine motor control. If you sort of move down to saliva, you know, many drugs cause xerostomia. Saliva has so many antibacterial properties, it washes, it buffers, so it's so many anti-cariogenic features that the quality and quantity of your saliva are very important to your caries risk. We can do bacterial counts looking for strep mutans and lactobacillus, and in general terms, the higher your strep mutans count is, or the higher your lactobacillus count is, the more likely you are to have caries. And right at the bottom, actually, as a professional, your hunch, and it's been shown that health visitors can do it as well, can predict families who are more likely to have caries, because you can take the patient as a whole. But it's very important to do a risk assessment, but actually to go through the step of making that risk assessment. So these caries risk assessment, the ICDAS system and the NEVAD both work basically on looking at the tooth wet and looking on the tooth dry. And if you look at both the occlusal surface and the mesial surface of this upper sixth, when it's wet, it's pretty hard to see what's going on. When you dry the tooth, you can see it. But actually, it's more than just let's blow dry every tooth and see what's going on, because actually dentine lesions are easier to see when they're wet. I'm now just going to trot through the ICDAS system. It's really a two-digit system where the first digit describes the status of the surface in terms of restoration from sound to crowned, with say a code 4 being an amalgam. But I'm going to just stick here to the second digit, which describes the caries status, which are 7 digits, which range from 0 completely sound to 6 a cavity you can park your car in. And I'm now going to go through each one of these in one by one. So code 1 you've seen before. It's an enamel caries lesion that you can only see when you dry the tooth. Code 2 is an enamel caries lesion that you can see without drying the tooth. So it's more advanced, it's been there longer, it's larger. Code 3, you're starting to see some breakdown in the enamel, but you don't think it's indenting. Code 4, this is the one you see best wet. There's a shadow, but you can't see a cavity, and the shadow's indenting. Code 5, there's a cavity. And code 6, there's a big hole, which actually is not defined as one you can park your car in, but is defined as one that involves more than half of the surface. So the ICDAS system is not particularly complicated, but what it offers is that staging from the first stage of the disease through. Of course, we're going to use adjuncts, and the most common adjunct we use is radiographs, and here we can see a lesion in the lingual fissure, occlusal fissure of a lower 6. And I must admit, I saw this tooth myself. I would have scored that an ICDAS 3, and of course it's much more advanced than that, almost halfway into denting. And I have another lecture on adjuncts, but that's for another time. But the next tricky thing is deciding on the activity. And if we look at the lesion on the lower left, the cavitated lesion, we know for certain that that is full of plaque and that is active. But the other lesions in this picture, it actually on a one-off appointment, even with the help of radiographs, it is impossible to know the activity of those lesions. Are they progressing? Are they stable? Are they regressing? No one knows. We've all seen self-cleansing lesions like the middle one in that lower 6, where we thought that shouldn't cavitate because books tell me it shouldn't cavitate, and it does. So you take all this information from your diagnosis, your risk assessment of the whole patient and of the tooth. You make an assessment in terms of the plaque, etc., and your risk assessment on what's the activity, and you come to a management decision. And then you explain that management decision to the patient. You explain what you've seen, why it's happened, and then you help them understand what you and they are going to do about it. And the main thing they're going to do is the preventive element. And I'm just going to take that bit of our conversation as read, that you're going to deliver prevention. So why am I turning to sealants? Because yes, sealants are effective at preventing caries. Cochrane review, here's the data. But actually now it's managing these minimal early state non-cavitated stages of caries. Coutu and Bonacor accredited with the first modern sealant study back in 1967. And if you read their paper and get towards the very end, they actually sealed over caries on purpose to see what would happen. But that really didn't really get noticed in the excitement of the invention of the modern fissure sealant. But they found that caries, they monitored it radiographically, and they found that the caries, and this was dentin caries, they called it incipient caries, but they meant dentin caries, didn't seem to progress. And then all these other people have done lots of studies using different methodologies, using radiographs, entering the pulp to do bacterial counts, etc. And these are not all the studies, these are just the studies I could fit on one slide, all showing that sealing over caries slows or arrests the lesion. There is one study by Vierheim from the Netherlands showing that caries seem to progress. She did bacterial counts. We're not, particularly in these times of COVID, it's no news to any of us that different pieces of research give us different answers, but we do seem to have overwhelming evidence in one direction here. I have a lot of time for the research of Karen Vierheim, and how can I explain this difference? Hers was retrospective, these were all prospective. That's possibly one reason for the different answer. But anyway, the evidence is overwhelming. If you don't believe me, this is the American Dental Association's view, clearly saying from their systematic review that you can use sealants to prevent the progression of non-cavitated lesions. So what do you do when you see these two lesions here? One of them we've seen before. I've got my radiograph. I don't see any occlusal caries into dentine. I probably would score that at an ICDAS 2. The other lesion on the right-hand side, yes, there is dentine involvement, less than a third of the way into the dentine. It's non-cavitated, it's an ICDAS 4. You manage these the same way, you seal them. And 9 out of 10 times that's going to work. In fact, there is some research that suggests actually it will work much more effectively than even 1 in 10. Maybe down to it's only 0.001 will actually progress. There are some studies going that far. I do think it's wise to monitor the lesions, and you can monitor them in 2 ways. One is you can use radiographs, and that's what most of us will do. The other image is of a Dagnodent, which is a laser fluorescence pen. It gives a reading. It will work through a sealant, so you can do a reading when you place the sealant, and if they come back 6 months later, you can do a reading again. And if that reading is markedly gone up, the lesion is progressing, and if it's similar, it's stable. So you do want to monitor. People will say, what if the patient doesn't come back? Well, you have to explain to the patient what you want to do, why you want to do it, and you need to monitor it. And if they vote with their feet, they vote with their feet. Sealant restorations, just in passing. I did a lot of sealant restorations when I first graduated, removing the caries, placing a sealant and sealing over the surface. Now, there is nothing wrong with doing a minimally interventive restoration when it's called for, and then sealing over the rest of the surface to make sure that it's all protected. That's good dentistry. But doing what's been called an enamel biopsy, or going that fissure is a bit sticky, and thinking I'll just investigate it and drill it out of it and stick some composite in it, is not good dentistry, because nothing we do will last. It will all fail. So this lesion here, whatever this person saw, because they aren't actually even into dentine when they've drilled it up, when they've placed this composite, this tooth should have just been sealed. So please don't do enamel biopsies or sealant restorations where you're just drilling it a bit just in case. So that's how we're managing early caries, and I'm concentrating mostly on occlusal surfaces. Sealants work. Deep caries, and this is where things are changing actually quite remarkably and quite rapidly. And this goes back to Fusiyama's work. So I said I would put a picture of G.V. Black up. Now, G.V. Black is a great man in dentistry, and you know, people have sort of said, oh, he taught over destructive dentistry, and yes, he did. But he had the equipment he had at the time, he had the understanding he had at the time, and his 2 volumes of operative dentistry published at the beginning of the 19th century. I will not claim that I've read every word of them. I've read bits of them, and there is an awful lot of a preventive attitude, and a lot of his teaching and ideas were absolutely right and don't ring untrue. Now, But some things he got wrong. And this is one of the things he got wrong. He basically said you couldn't leave any caries over the pulp. And it's this concept, as I said, of caries being like gangrene. And that if you leave any behind, it will just progress and the tooth will die and the tooth will be lost. A little bit before him, John Tomes, who's well known to the college, who I must admit, looking at this picture, didn't look like a guy to have a fun night out with. But anyway, in terms of this subject, he was right. He suggested back in 1859 that actually it was safe to do an indirect pulp cap, and it was much better than exposing the pulp. But what he said got forgotten until the 1990s, really, and we remembered what G.V. Black had said because of his influence on so much of dentistry, I guess. So, managing deep caries, what are our options? Well, we can do a direct pulp cap. So we remove as much of the caries as we can, and when we expose, if we expose, we put some material on the pulp to help it heal. And historically that would have been calcium hydroxide. We now might use materials like biodentine or MTA instead of that. The problems with that are that you are likely to spread bacteria into the pulp. You're likely to bring infected dentine into the pulp, and by going so close to the pulp, you're going to be generating heat near to the pulp, and pulps don't like heat. So that's why that's in red. Not saying it doesn't work, but the evidence shows much lower success rates than the other more minimal techniques. So the next is stepwise excavation, and the idea here from the papers of Brondal is that you would remove enough caries so that you could place in a restoration, and that restoration would then isolate the caries from the biofilm on the surface, the same way as a fissure sealant is isolating the more minimal caries from the biofilm on the surface, and therefore the caries would slow or arrest. You would then wait some months, you go back in and remove more caries, and perhaps repeat that procedure one more time before finally putting in your definitive restoration. Why have I got that in amber? Because it does work, and people have advocated it because dentine shrinks as the caries dries out, and people worried about putting restorations directly over caries and not going back in. So that was one of the reasons for stepwise excavation, but it works. You get fewer pulpal exposures. I'm going to put up a Cochrane review that confirms that in a moment if you use stepwise. But in fact, the evidence increasingly knows that if you use selective caries removal, which I've called an indirect pulp cap here, but should have possibly used the better term and separate the whole technique, but just actually go in, make the margins caries free, so the ADJ is caries free, and place your restoration, your outcomes are better than the other two. So I could have put this in green, as could I for the partial pulpotomy and RCT, which I'm going to come to for lesions where we're actually now in the pulp. And traditionally, what we would do if we're in the pulp is we would do an RCT. But the research is showing that we've always done pulpotomies in paediatric dentistry, and I'm not talking about pulpotomies in paediatric dentistry, I'm talking about pulpotomies on permanent teeth. And instead of going straight in and removing the tissue from the root canals, we can just remove the coronal material, which is more infected, or perhaps just a little bit of it, and avoid the need for an RCT, which is quite a leap forward, and a huge leap forward if you think where we were 20 years ago, 30 years ago in our management of caries overall. So a little bit more detail on that. This is the data from the Cochrane review. As with all Cochrane reviews, its conclusion is a bit wordy. But what it says here is that if you use stepwise caries removal, or if you use partial caries removal, you get less pulpal exposures, and you get fewer pulpal exposures with partial caries removal compared to stepwise. And the literature supports that, and literature that's come along since then supports that. The whole technique, just jumping into management of paediatric cases, is a version of this. It's an indirect pulp cap. Okay, we do no caries removal. We just stick a crown on over the caries, and by isolating caries from the biofilm on the surface, we stop the caries. You can use a whole crown right up until there is a minimal bridge of dentine visible on an X-ray. So people tend to say if you can see a millimetre of dentine, it's safe to put a whole crown on. So that's exactly what we're saying about adult teeth, but here in primary teeth, if you think about it. And so I'm just going to present one bit of whole crown data just to support that claim I've just made. This is from Nicola Innes's and David Evans's first study, and this is the follow-up study where they went back about 5 years later and looked at what had happened to the teeth in the original study. So how many of them had exfoliated without causing a problem. So by this point they had 101 children, still 17 GP practices, 184 teeth, 73% of the original sample, split 50-50 between the conventional and the whole arms of the trial. Conventional, the dentist got to treat the way they liked. And they found really the figures are overwhelming. 88 of the remaining whole crowns had exfoliated without problems, as opposed to 48 of the conventionally restored. The numbers that don't make up, either they didn't know what had happened to the teeth or they were still present. And then the other references are all other studies that give exactly the same evidence in favour of the whole technique. It's child friendly, it's quick, it's effective, and there's good evidence that it's actually a cost-effective way to manage children's teeth. And if you look at the picture on the top right, you also don't take a chunk out of the two adjacent teeth when you're doing it, as happened here, unfortunately. So, going back to permanent teeth, and I talked about selective caries removal. Way back 1979, Mette Fairhurst did this classical study where she did ultra conservative caries removal. She just removed it to the AGJ, as I've said. And in her classic 10-year study, she compared that with removing all the caries and placing an amalgam which she sealed, but she didn't worry about cavo surface angles or overhanging amalgam or any of that. She just removed the caries, stuck the amalgam in and sealed it. So no extension for prevention or any of that. And she did classic Black's extension for prevention. And at the end of 10 years, she found that the ultra-conservative and the sealed amalgams performed equally well, but the group of extension for prevention, which was taught as perfect and right dentistry, and was what I was taught, as Matthew said, not many years later at Edinburgh, as how I was to manage caries, was the least successful. And I'm really lucky here to have some of Mette Fairhurst's original slides and radiographs. So we're looking at the upper six, and we can see the occlusal caries. And this is at baseline. That's Dutch you're reading there. And so that's the tooth, and then that's the tooth after they've opened it up and removed the caries at the margin at 2 sites. And then this is the tooth after they placed the composites. Remember, these are not posterior composites. They didn't have it back then. This is concise anterior composite. And then they've sealed it. And then this is it 10 years later. Still some sealants there, some failure of sealants as well, but not doing bad. And then this is the lesion and no progression. And you can see how minimal those composites are. Which brings me to just mention in passing the SCRIPT trial, which is a trial being run between Aberdeen, Dundee, Sheffield and Kings. And I apologise if I've forgotten any of our partners. And it's looking at precisely that, except in the arm where the control arm, we're not doing extension for prevention, but we're going to the point where we can't excavate anymore, but leaving caries compared to just that very minimal selective approach. This is going to be done in general practice, or is being done in general practice. And in a few slides, I'll beg for volunteers to join us and help us. So I'll mention this in passing, but if you're going to do indirect pulp capping or selective caries removal, you don't play chicken with the pulp, and you remove as minimal tissue as possible and keep your pulp your burr as far away from the pulp as possible. So as I said in my introduction to this, now if you go even further and you go into the pulp, pulpotomy is more successful than direct pulp caps. Use a calcium silicate cement such as Biodentine. RCTs have good outcomes, I've got no doubt about that, but they can be really technically difficult. And the early research we've got are saying that the outcomes of RCTs at 5 years and the outcomes of pulpotomies at 5 years are similar. Of course, there are issues about diagnosis, and once you've got non-vital tissue, once the root pulpal tissue is dead, you have to do an RCT. So this is where you've got irreversible pulpitis, and where you might be along that diagnostic staging. So we've got staging of the caries process. We now need to start staging the status of pulps, but we actually are not as bad at that as we might think. And I'll just draw your eyes down to the paper by Edwards et al. From 2020, who do an excellent review article on this subject. These are the two trials. We've got SCRIPT, which I've talked about, which is selective caries removal, and we've got PIP, which is pulpotomy management of irreversible pulpitis, and that's looking at doing pulpotomy versus RCT and the outcomes again. Both trials in general practice across Scotland and England. If you are interested, there are the web addresses. Please volunteer, because it's exciting research that really could make a very big difference to dentistry and a very big difference to your lives and your patients' lives. But we need the practices to volunteer to do this research. So, silver bullet. That's Sloan Trainee Jr. as the Wolfman, and we know he was killed by the silver bullet. And this could be a silver bullet. This is silver diamine fluoride. We're looking at the packet there. The silver containers contain the SDF, the silver diamine fluoride. What happens is the silver is antibacterial, the fluoride promotes remineralization, and the silver also forms a protein complex on the surface of the tooth. The lesions go black. Caries is brown or black anyway, so that doesn't really bother me, but it is an issue that you have to discuss with your patients if you're going to use it. To combat that, the green containers contain potassium iodide, and after you've applied the silver diamine fluoride, which you paint on the tooth, you dry the tooth, you paint it on for 1 minute to 3 minutes. I've yet to manage 3 minutes because it's a long time in dentistry. You then paint on the potassium iodide, and when it goes white initially, and when it starts to go clear, you've applied enough. And what it does is it removes the residual silver and perhaps some of the silver from the surface, and it's supposed to stop as much staining. Some people worry it may also affect the effectiveness of the juries out there. Silver diamine fluoride is showing remarkable, it's not new, again, it comes from the 1960s in Japan, but it's very new to Europe and North America. It's showing, the research shows remarkable effectiveness in terms of arresting caries lesions, up 66% plus. It also is effective at preventing caries, and we use it to prevent caries. If there's no caries present, it doesn't result in staining. As I said, I'm really interested in the erupting tooth, and I'm just going to put forward a way of managing erupting teeth and preventing caries in them. People have looked at oral hygiene, yes, and up here the work from Cavaro and Ekstrand. Teach your patients to brush the teeth from the side, because otherwise the toothbrush doesn't touch the teeth. Yes, you can use fluoride varnish, it's effective. Might be small print, but chewing gum's effective. Coarse diet advice is effective. Should have put SDF will be effective at preventing caries. There's evidence for that. Why are erupting teeth so prone to caries? It's because they remain covered in plaque. If you've got plaque, you get caries. This study here, they just looked after cleaning what the plaques up, how much plaque built up after 48 hours. And because your teeth come into occlusion when you're eating and all through the day, you clean your occlusal surfaces to a degree. But erupting teeth, because they're not in occlusion, don't clean. It's as simple as that, and that's why they get caries. And teeth actually take quite a long time to come into occlusion. 6s and 7s can take up to 3 years to do it. So what to do? You've got your erupting tooth. Teach your patient to brush from the side while the tooth's erupting. If they listen to you and keep their teeth clean, you put fluoride varnish on it. If they don't, and the teeth's covered in plaque, you do a glass ionomer sealant. You can't do a resin sealant because you can't get the isolation. And that way you put a mechanical barrier on the tooth, and therefore the tooth is isolated from the plaque on the surface, so it won't generate caries. And then depending on whether they do change their ways, you manage that tooth either by maintaining the glass ionomer sealant or by placing a resin sealant. And if they do start to maintain their oral hygiene, you can go back to just applying fluoride varnish every 6 months. I said there was a couple of thoughts I wanted you not to take away from tonight, and the first one is caries is driven by the biofilm on the surface, and whether it's initial caries or deep caries, if you can isolate the caries from the biofilm, it will arrest. Another is the importance of your diagnostic process to your treatment planning. I hope I've covered all of these. I know some of them I've done in quite a superficial level, but I hope I've pointed you to the literature where you can delve in a little bit more. I also hope I've made you interested or encouraged you to be interested in maybe helping with some research so we can actually take this forward, because it is really exciting times in cariology. And with that, I'll say thank you very much.
Thank you, Chris. It's Jag Dander here. I'm board for FDS and a consultant maxillofacial head and neck surgeon down in Brighton. Really enjoyed that. A little bit out of my depth in terms of the level of knowledge here, but I've got a few questions that have been posed by the attendees. I'm pleased and delighted to tell you that you have one of the highest numbers of attendees so far in the FDS webinar series, so congratulations. First question.
Thank you for coming out or staying in. Yeah.
First question is from Maria Kyriakidas, who has just asked, do you seal over the caries when it's in the enamel only? So she missed a little bit of part of the study, the early part of the presentation. And then one from Jill Phillips. Would you normally suggest complete caries removal for deep carious lesions to ascertain the depth of caries when the patient is in the mixed dentition, and timely removal of the tooth could be considered?
So if we're talking permanent teeth, I would manage permanent teeth the same way as I've outlined here. I don't play chicken with the pulp. Don't go near the pulp. Give it its best chance, because the biology or the pathology of caries doesn't alter just because you're in the mixed dentition. Now, I take a lot of first permanent molars that are poor prognosis out. So if I'm in any doubt, I do plan the removal of that tooth in consultation with an orthodontist if that's required. So it's not that I heroically try to save all teeth. I think, you know, around the age of 8 to 10, if you've got a tooth with a significant caries lesion, its prognosis is very poor, and maybe going in the bin is the right thing for that tooth. So it's a case by case basis. But if you move that patient on into their teenage years, maybe at 14, there's no advantage to losing it early, and you lose nothing by trying to save it. But in the early one, yes, I would plan the loss of the tooth. I hope that answers it. It's an easier question to answer if you stick a case in front of me, but hopefully that answered it.
Okay, next question is from Alice Shaker. What is the difference in depth between stepwise excavation and indirect pulp capping?
It's a nuance of terms, and I'll be honest, I've been a little bit sloppy with my use of the two terms. Stepwise, you go as far, you just get past, like you do in selective caries removal, but the plan is you go back in later on. Traditionally, people with indirect pulp capping would go closer to the pulp to try and remove more of the caries, but increasingly the evidence says to us, don't do that. Just get, like Met Fairhurst did, do what she did all those years ago and just get a good seal at your margins, isolate the caries and monitor the tooth, and don't stay as far away from the pulp as you can.
Super, thank you. Another question from Maria Kyriakides, who has asked, do Hall crowns work for adults?
There's no reason they wouldn't, but I don't know many people who are putting them on, but they would work for adults, and you do get preformed metal crowns that fit really well for adult molars. The ones for premolars are not very anatomically correct and are very not great, but there's no reason you couldn't do that. Your issue is longevity. That whole, preformed metal crowns do perforate and they last years though. So there's no reason why you couldn't, and there's no reason why you couldn't as your initial treatment to hold things.
Super, thank you. We've got a flurry of questions coming in, Chris, and I'm conscious of the fact that we have only 5 minutes left in the 1 hour allotted, so I'll try to get through these as quickly as I can. Another question from Alice Shaker. My memory of MICDAS is 0, 1, 2, 3, 4, but you have said 5 and 6. Is this a new development? Is it mentioned in the late Picards? And would you be able to explain it in the way it's mentioned in Picards?
I have a copy of Picards. I can't remember how. I don't know how it's said. I know ICDAS has not ever changed because I was there right at the beginning of its development.
Yeah.
So I can't explain that.
Okay. Debbie Hemmington has asked, SDF is not licensed for caries. Where do we stand using it off license?
We use many things off license, and there is no issue using it on license. Our pediatric colleagues use many drugs off license without any issue, and so you'll have no problem using SDF off license. I think it is important to tell the patients about the staining issue, even though I might think your teeth look black to me anyway. They do get blacker, so I think it's important to do that bit and make sure you've got consent. But we use many things off license, so I wouldn't worry about that.
And
there's the article, sorry to interrupt, the article by Laura Timms, which is actually in Dental Update, talks about that really quite well if you want to go and have a read up on that issue in more detail.
okay. Marion Stanfield has asked if you use SDF on hypomineralized first permanent molars.
Yes. Now, the evidence is only anecdotal, and my experience of it is very, very limited, but I've got colleagues in America who use it a lot on hypomineralized first permanent molars, say it works really well to reduce sensitivity, and sing its praises. Now, that's anecdotal. I don't have enough experience to say that that's my experience yet, but lots of my colleagues tell me that. So the answer is yes, because I believe the people who are speaking to me.
Okay. And this is a practical question from Dana Rosenthal. If you're treating a child with learning disabilities who is unlikely to manage replacement or checking of a fissure sealant, and the child requires a GA for caries, would you still fissure seal the 6s under GA, considering the risk of these failing versus the benefit of them staying in situ?
I would absolutely seal the 6s, because the evidence is clear that if a partially sealed tooth, or if your sealant is lost, the tooth is no more caries prone than if it was never sealed. And if you've got part of a sealant, that doesn't make the bit of the tooth just adjacent to the sealant more caries prone, because none of the studies that have looked for that have found that to be the case. Because I know it's one of the things people are told and people believe, but actually, yeah, unequivocally, seal the tooth. You will only do benefit for the length of time the sealant is there. And when the sealant is lost, the tooth will be as if the sealant had never been there.
Okay, I guess you've answered the next question by Abida Raja, which is, what are your thoughts on the quality of sealant? If poor quality, is tooth potentially worse off?
No, because if it's a poor quality sealant, it'll fall off. So
okay,
don't do any harm.
I've got one more question for you, Chris. You've concentrated on occlusal caries. What are the options for proximal caries, particularly with the less advanced lesions? I remember attending a lecture on microinvasive treatments of early non-cavitated caries. I think it was ICON by DMG. What's your thoughts on that?
Yeah, I don't do a lot of ICON because it's quite expensive. That's one of its problems. But yeah, you can do first line treatment is all the preventive things I've taken as read, plus putting fluoride varnish on, using infiltration, which is ICON. I don't have time here to describe it, but it's resin infiltration. 80% of lesions will arrest using ICON. If you don't have ICON, actually about 50% of lesions will arrest if you just seal them. And the other thing is that magic bullet. If we forget about the staining issue, SDF might be your other option.
Super. Thank you. I think that's it. We're going to wrap things up. Really delighted that you could give us your time in the evening, Chris, and it's been a fantastic webinar. We will be recording all of these webinars, and they will be freely available or available for restream for RCS members. So please look on the website for further information of future webinars and accessing previous webinars. So thank you, Chris. Have a good evening.
Thank you. My pleasure. Everyone else have a good evening too. Bye.
Bye.